Ma'am, we are going live in 3, 2, 1. Please start.
Okay. Namaskar and good evening, everyone. I welcome you all for today's webinar on Breast Cancer Updates 2021. I have immense pleasure to welcome Dr. Chandragoda, who is Associate Director, Medical Oncologist, BLK Super Specialty Hospital, for the introductory and welcome note. Over to you, sir.
Thank you, Surgeon, and thank you, Ekta and Pooja, for making this event the West. And now, just it's that we are going to start with the talk, or just have to give an overview.
No, you're welcoming everybody, and now we can start with the talk. So what I can do is,
okay. You welcome, Surgeon.
Yeah, thank you so much. So the things which are going to focus over the next 1.5 hours are what is evolving, especially in HER2 positive, also in triple negative breast cancer. So we can't cover these topics because they are very, very large topics, but yes, certain insights into the topics will start. So we'll first start with Dr. Chandragoda's lecture, and I hope that will be a great, I would say, it's a kind of need of our for our PG, especially to understand what is happening in HER2 positive breast cancer. So over to you, Dr. Chandru, for the first presentation.
Thank you, Dr. Surgeon. So I think my slides are visible.
Yes.
I'm audible, right? Thank you.
Yeah. Make it full screen, sir.
Yeah,
Just
done that, right?
Yeah. Oh, that's okay. Okay.
Great. So my task today is to speak on optimizing treatment strategies in neoadjuvant treatment in the management of HER2 positive early breast cancer. So without wasting time, I'll just proceed forward. And this presentation was provided by Roche, and this is how we have evolved in a HER2 positive breast cancer scenario, where it's a biologically complex disease. So today, when you talk of HER2 positive disease, so we have HER2 new 3+ by IHC or HER2 new positive by ISH, and we talk of either hormone positive, hormone negative with the HER2 positivity. So if you go to the cell line features, so we have various mRNA, microRNA, proteins, DNA copy numbers, methylation, DNA mutations. So those would harbor the prognosis in patients who have HER2 positive disease. And we also talk of tumor infiltrating new lymphocytes, more so in triple negative or not, and also in HER2 positive disease. This is how the neoadjuvant therapy has evolved in patients with the HER2 positive disease. Then we had only chemotherapy and endocrine therapy, and there the aim was to reduce it to an inoperable to an operable stage. Now it's completely different. So what we has transcended with the advent of trastuzumab in HER2 positive setting has changed the gears into a curative approach and approach the HER2 positive patients more not only from the response point of view, but from the point of survival and better survival. So that's how the aim has changed. Now, why we should need an neoadjuvant therapy in the current era? Of course, it facilitates by shrinking the tumor from MRM to a breast conservation. It also risk prediction for the PCR, as the pathological CR has a connotations regarding the prognosis as well as the treatment implication. So, and the response adjusted therapy, as I said, the PCR connotes that you need to probably change to some other adjuvant strategy. So this is how the neoadjuvant therapy has evolved. And then the response evaluation. When you talk about response evaluation, when you administer the treatment, the marker of response can be clinical, pathological, molecular, and imaging. So there are various, the studies which are dealt on with respect to the treatment post neoadjuvant treatment. We have clinical radiological phenomena of CRPRS, DPD, and pathological by PCR and molecular by Ki67 and circulating tumor cells, imaging characteristics of PET or PET MRI combination. The ultimate clinical outcome of these marker analysis is the local control, the disease-free survival, and the overall survival. So when you talk of HER2 positive or a triple negative subset, we need to know about pathological CR. So that's very important endpoint, as it is a surrogate of survival. So there are various guidelines which have postulated whether PCR would be a total, that is a stringent PCR, or it is a BPCR. So the guidelines that if there's an in situ carcinoma in the breast or in the node, so that's PPCR, and if it is a total PCR, which you call TPPCR, where it is a YPT0 and in situ N0. If it is everything negative as per the German breast group, which is a stringent PCR, where they don't consider even in situ there, so it should be completely negative. That is what we call it as the stringent PCR. So the pivotal neoadjuvant clinical trials in this particular setting. So to start with, this NOH study, which was done both HER2 positive and HER2 negative. I will concentrate only on the HER2 positive subset in a stage 3 breast cancer, and they was divided as a small study for 250 patients, and they were divided into patients who have received the trastuzumab and with an anthracycline, and followed by surgery without the trastuzumab. So the outcome of this study is that the patients who received a trastuzumab, there's a significant increase in the PCR rate. If you can see here, see the PCR rate is jumped from 26% to 65% in patients who have been treated with trastuzumab. So that indicates that the PCR increases on adding trastuzumab. So if you talk of EFS and OS, which is a surrogate of what the response is, and then you can see clearly a red bar suggesting a patient's receiving trastuzumab clearly benefiting with the trastuzumab, addition of a trastuzumab over chemotherapy. So because it's a small study, there was a trend towards EFS and overall survival benefit with the addition of trastuzumab to chemotherapy in HER2 positive patients. So this was an addition of only one anti-HER2 therapy. Can you improve on this particular pathological CR? That's what the question asked. That's when the pertuzumab as a dual second anti-HER2 therapy was added to existing trastuzumab. So can you improve upon the pathological CR which was existing, which was to the tune of around 40%? Now the pertuzumab is one which has which adds to a HER2 signal and probably dimerizes. It just dimerizes to the other partners in the sense that it acts on the HER2 and then it helps in dimerizing with the other HER2 partners. So now we have data from dual anti-HER2 from Neosphere study and TIFINA. So first of all, covering the Neosphere, which is a randomized multicenter open label phase 2 data in HER2 positive patients who have T2 to 3 and N0 to 1 and or inflammatory breast cancer. They should be chemo naive and the primary tumor should have been at least more than 2 centimeters. They were randomized to either receive TH, THP, HP, or TP. So THP was pitted against all these regimens for a comparison, and the primary endpoint was PCR rate. That was the primary aim. If you can see the pathological complete response, their definition was T0, YPT0, and in situ in the nodes was also pathological CR. If you can see the green bar, which is 48.5% path CR in a THP group, so docetaxel, trastuzumab, and pertuzumab. And this was compared with others. So the interest was 29%, where it was only without pertuzumab. So there's definitely incremental benefit when you add pertuzumab to a trastuzumab. When there is a 5-year follow-up data, PFS by total PCR rate. So all treatment arms combined in an intention to treat population. So TP-PCR was 85% versus 76% without the pertuzumab, which was with a hazard of 5, which was significant. So this was one trial. And another trial is a phase 2 study of pertuzumab and trastuzumab in the neoadjuvant setting. Was FEC followed by docetaxel. So the pertuzumab trastuzumab combination FEC and followed by docetaxel. This is where they combined anthracycline together with the anti-HER2 therapy, which was not doing it. So then followed by trastuzumab for 1 year in early breast cancer. These were the primary endpoint, the safety as well as the tolerability was considered, and then the secondary endpoint was the PCR rate here. So if you see the PCR rate in the TIFINA, so the green and the pink bar, if you can see, that is with or without the pertuzumab. So there's some sort of 5% increment on addition of the TCHP. So if you can add P without P, so with the P, definitely there is addition of 5% increment in the PCR rate. But if you subdivide them into hormone negative, hormone positive, there will be incremental benefit with addition of the PCR. So this is what I was just talking about. The PCR is stratified by the hormone receptor status. So in patients who are hormone positive, ERPR negative, and in patients who are ERPR positive, in that they just see the 83% patients have achieved a PCR rate. This was 79% without this thing. And then the FVC followed a pH versus TCHP remains the same. But if you compare these two with FVC followed by PHT, that's where the PCR rate is bit less. So addition of pertuzumab definitely is adds on to the benefit. So there are other trials where sometimes a patient cannot take the chemotherapy with an anti-HER2 therapy. So what else we can offer? Can you offer dual anti-HER2 therapy without chemotherapy? Yes, you can do it, but the path-CR is not that significant. So we have seen in NeoSPEAR, the PER2 and TRAST2 has resulted in only 16.8% of PCR rates, and that is very less in patients who are hormone positive. So also addition of lapatinib, trastuzumab, or lapatinib, any of these agents without chemotherapy, the PCR rate is less than 30%. So what is the correlate when you talk of pathological CR? As we say, it is a pathological, the CR it correlates to the overall survival. Do you have any evidence for it? So there's an association of pathological CR rate with event-free survival in HER2 subtypes. So if you see this, analysis, and if it's this analysis has shown, the pooled analysis of various studies have shown that the addition of the path-CR correlates with the survival that favors that there's a path-CR has a significant favorism towards the overall survival. So irrespective of hormone receptor status. So if patient achieves a path-CR, that is surrogate of overall survival. So again, reiterating the fact, the pool analysis from the various neoadjuvant trials, all patients HER2 positive and HER2 positive, HR positive, and HER2 positive, HR negative. In HR negative, the benefit is incremental. In a patient who are hormone positive, the benefit is not that robust, but still it's significant. So patients who achieved path-CR had a better long-term outcome than those who had a residual disease irrespective of the hormone status. So 3-year EFS also, if you can see, so EFS in patients who achieved path-CR by treatment modality. So the patients with the path-CR, so at 3 years, just wound up saying that the patients who had path-CR still had a higher risk of recurrence, and this risk was small in patients who received the PH followed by PH. So there's some data saying that would you do a PH followed by PH, or we just do a PH followed by H? So there's some data saying that PH followed PH probably is better in terms of event-free survival at 3 years. We do it more commonly when the patient has high burden disease, there's node positivity up front. So to summarize the pooled analysis from this, overall the patients who attained path-CR had a better long-term outcome. Some patients who had a path-CR still has a risk of recurrence. Therefore, the standard of care should be given in the adjuvant setting. And EFS appears to be highest in those patients whom we give PH followed by PH. So that's what the data suggest. And you can see the guidelines with respect to that. The patients who are HER2 positive, the preferred regimens are definitely the TCHP. So we all definitely, as an institutional practice, patients who had more than 2 centimeter lesion, if you have to offer neoadjuvant, usually go for TCHP. Very rare circumstances where the comorbidities and all the payroll, then probably you can go with the paclitaxel trastuzumab as a regimen. So that's it. A lot of us, we are following TCHP as a regimen upfront. So with that, I conclude my talk. Thank you very much, Surgeon, and thank you everybody for giving me an opportunity to talk. Thank you very much.
Thank you, Dr. Chandu, so much for such lucid and very crisp talk. And I think that's what all these have been landmark trials that have shown the path to the progression of HER2 directed therapy. One question is that is there a better approach for hormone for like triple positive patients? Is there some new data where if intensification or some combination with hormones can make things better, or we still use TCHP for our patients?
If you neoadjuvant, it has to be TCHP, but the TDM1 plus fulvestrant doesn't result in that kind of a PathCR compared to TCHP. So there the PathCR is up to the tune of around 40%, but if you TCHP is, it goes beyond 50% even hormone positive. So I would still use TCHP, but post 1 year addition of niratinib and hormone positive, that's what probably we take it into. But that was without TDM1 data. So in that context, TCHP will definitely be enough.
So most clinicians end up using TCHP.
Yeah.
Any specific setting where adding anthracyclines might benefit? Like
anthracycline, we have a recent data saying that adding an anthracycline may be a plus minus, but earlier we used to consider in patients who is hormone positive, HER2 positive, adding AC or TH, where we used to do it because of to achieve more PathCR. But now recent data suggests that anthracycline may not be, add on to what TCHP has.
Thank you so much again. And we'll take the session the next topic. And the next topic, Ekta, the next topic, I think Dr. Devrat
yes. Yeah. New paradigm approach in treatment of PDL1 mTNBC with Tecentriq. So for this, I would like to invite Dr. Devrat Arya, Director Medical Oncology, Max Hospital, Saket.
Okay, so I think the meeting is
start, sir.
Yeah, so good evening, everyone, and thank you for this opportunity to talk in this meeting. And the mandate that I have today is to talk briefly about the role of immunotherapy in advanced breast cancer, and the focus today is going to be Tecentriq. So we know breast cancer is one of the most commonly diagnosed cancers worldwide, and it's one of the most commonly diagnosed cancers here in India as well. In fact, the numbers in the urban centers are very high. We know it's a heterogeneous disease. Historically, the outcomes have generally improved, but we also understand that the subtype triple negative breast cancer is a challenging subtype to treat. So traditionally, we've divided breast cancer on the basis of ER, PR, and HER2/neu expression. TNBC, by definition, is a tumor that lacks expression of all these three receptors. Approximately 80% of these fall into the basal-like, based on the gene expression analysis subtyping, and these are the more aggressive subtypes. And when you talk about TNBC, there are also 6 unique subtypes which have been identified so far. So what are the characteristics of TNBC? I think we all know that they are more likely to have grade 3 histology. They are usually larger tumors. They are associated with higher mortality rates. They are generally more aggressive, and they have higher rates of distant recurrence. And clearly, TNBC, especially in advanced stage, has a significant unmet medical need in terms of the treatment possible. Incidence fairly high, nearly 10 to 20% of all cancers worldwide are triple negative. I think when we talk about Indian subcontinent, there's data to suggest that the component TNBC is actually a little higher in terms of incidence at 27 to 35%. Unfortunately, the way disease presentations are here in India, nearly half of these patients actually present with a more advanced disease. Even in Indian population, the median age is younger. A significant number of patients are less than 50, and in fact, cases have been reported at as early at age as 22, and the median age of presentation is 49 years. So clinical outcome, as I said, long-term outcomes with triple negative breast cancer are much more dismal as compared to other subtypes. And when you talk about how this disease is aggressive, how treatment options are limited, I think, as I said earlier, this is a significant unmet clinical need in the field of oncology, and particularly breast oncology. Now, these have been the treatment paradigms for triple negative breast cancer. So we know for metastatic triple negative breast cancer, taxanes usually have been the first line therapy. If a combination needs to be used, taxanes are usually combined with carboplatin. For most second line triple negative breast cancer, the options include either capecitabine and eribulin. But clearly, when you look at the options As I said, anthracyclines and taxanes are options, but these options would also be governed by the need for combinations which can work faster and are associated with overall higher response rates, may also be associated with higher toxicity. So the need for a faster response, but also the performance status of the patient, the possible adverse events, and the patient preferences as well. So this is a graph which actually shows what the dismal outcomes with various standard chemotherapy regimens in metastatic triple negative breast cancer has been. And as you would note that survival is dismal irrespective of whatever chemotherapy has been used, and irrespective of whether a single agent is being used or a combination is being used. So with that backdrop, I think early research also has suggested that triple negative breast cancer may be associated with much more higher mutation rate. In fact, mutation rates may be as high as 13 times to what we see in a normal cell. And also that there is a uncharacteristically higher TIL infiltration in triple negative. So you have much more higher tumor infiltrating lymphocytes. We also know that when you have subtypes of breast cancer where TILs are high, for every 10% increase in TIL, you'd actually have some correlation with the risk of death and risk of distant recurrence and risk of overall outcomes. We also know that PD-L1, which has traditionally been used as a biomarker for response to immunotherapy, has been highly expressed. So the numbers would vary on the companion diagnostic that you use, but initial research did suggest that for triple negative breast cancer, nearly 50% women had a PD-L1 positivity. So high amount of TIL, higher mutation rate, and a significant high PD-L1 expression actually predicted for a possible responsiveness to immunotherapy, and that's how early studies started. And in fact, with PD-L1 or anti-PD-L1 therapy and anti-PD-1 therapy as well. And that is how those studies came into being. And one of the first phase 3 trials that was reported was the IMpassion 130 trial. I think we are all aware of this trial, but briefly, this was a phase 3 study in advanced treatment naive metastatic breast cancers. So these patients could have used taxane or anthra in the neoadjuvant or adjuvant setting, but they could not have received it in the metastatic setting. And these patients were then randomized to receive atezolizumab, that is Tecentriq, in combination with nab-paclitaxel. And they were compared to those who received placebo with nab-paclitaxel. And the co-primary endpoints of this study was PFS and OS. Importantly, they included all comers in terms of PD-L1 expression. PD-L1 expression based on immune cell of positivity of 1% or more or less was one of the stratification factors, and so was presence or absence of liver mets or prior taxane use. Nab-paclitaxel was used because there's no need for steroid pre-medication. It does appear to show similar OS in comparison to paclitaxel, and the 100 milligram per meter square dose is the weekly regimen is actually one of the most commonly used regimen with this drug. So this is the patient disposition from the study, and this is the baseline characteristics. So very balanced baseline characteristics, relatively young median age at around 55 in both arms. Nearly 63% patient had actually received a prior anthracycline or taxane. Most of the patient had a significant disease burden, and nearly 41% in both arms had a PD-L1 expression, that is IC, of more than 1%. So what were the outcomes? So this is the primary PFS analysis. Remember, this is the intent to treat outcome. So median PFS was improved from 5.5 months to 7.2 months. With the addition of atezolizumab to nab-paclitaxel. So this is a 1.7 month statistically significant improvement. When one did the analysis based on PD-L1 expression, in the PD-L1 positive population, the median PFS was actually 5 months for nab-paclitaxel, and it rose to 7.5 months for atezolizumab with nab-paclitaxel. Again, a significant improvement in progression-free survival. The first interim analysis also showed a numerical higher overall survival, 21.3 months for the combination versus 17.3 months for nab-paclitaxel alone. This is a 3.7 month improvement. And again, when you looked at the data from PD-L1 expression, the median OS for the comparator arm, atezolizumab with nab-paclitaxel, was as high as 25 months, which was much higher than the 15.5 months that was seen with nab-paclitaxel. Whatever was PFS subgroup analysis, uniform homogeneous outcomes, homogeneous improvement in progression-free survival, irrespective of presence or absence of liver metastasis prior taxane used. And if you look at the entire subgroup, in fact, there's a homogeneous improvement in outcomes with the addition of atezolizumab to nab-paclitaxel. Overall responses, numerically higher responses, numerically higher complete response rates as well. And when you look at duration of response, again, atezolizumab actually improved the median duration of response in both the arms, both PDL1 and positive and PDL1 negative compared to nab-paclitaxel alone. Adverse events, there were slightly higher adverse events in the atezolizumab nab-paclitaxel arm. Most of these adverse events were minor. There were only a few grade 3 adverse events. Hepatitis was high, but most of these were laboratory anomalies. Hypothyroidism was significant in atezolizumab arm, but most of it is grade 1 and 2. In fact, pneumonitis, which was a concern prior to the study, was actually infrequent in both the arms. The most common adverse events were alopecia, fatigue, nausea, diarrhea, generally uniform in both the arms. And the most common serious adverse events actually included pneumonia, UTI, dyspnea, and pyrexia. But when you look at the percentage, increase with the addition of atezolizumab, it's usually less than 2% in both the arms. So while overall serious adverse events were higher, the actual difference was very small. So we have had some updated efficacy analysis as well, and in the overall improvement in outcomes, especially overall survival, has been maintained with the updated analysis, particularly in the PDL1 positive population. There's a significant improvement in overall survival with the addition of atezolizumab to nab-paclitaxel compared to nab-paclitaxel alone. And in fact, even in the updated safety analysis, there are no new safety signals. So I think from this study, there were 3 learning points. It did demonstrate a benefit of addition of immunotherapy to chemotherapy, that is atezolizumab to chemotherapy in metastatic triple-negative breast cancer. It actually provoked a change in the paradigm of treatment in the first-line setting for these patients. The overall hazard ratio of PFS in the intent to treat population was 0.8. But when you look at the PDL1 positive population, the hazard ratio was very impressive at 0.62. There was a clinically meaningful median overall survival, which exceeded 2 years. There are no new safety signals. And in fact, the study also helped in identifying a biomarker, that is PDL1, for choosing and selecting patients who could have been, who can be benefited with the addition of immunotherapy. Now, we've had some other studies as well, including the Keynote study, where the addition of another immunotherapy to chemotherapy has shown benefit. And I think overall, this is a proof of principle that in PDL1 expressors, you would have benefit with the addition of immunotherapy to the chemotherapy backbone. I think one of the key question of late that has come up is the US FDA indication for Tecentriq. So Tecentriq or atezolizumab has a regular full approval from DCGI based on the IMpassion 130 study, and there's been no change in the regulatory guideline when it comes to India. There has been a US FDA withdrawal, and that's because of some of the initial studies from the IMpassion 131 study, where in fact, when Tecentriq was added to paclitaxel in the PDL1 positive subset, improved outcomes were not seen. Now, we don't know what led to that difference in outcomes, whether it was the chemotherapy arm, which was paclitaxel and not nab-paclitaxel. But again, the US FDA did say that the withdrawal was not because of a new safety signal or new efficacy signal. In fact, they've continued to maintain that safety efficacy is maintained, and therefore, for all practical purposes in our country, the DCGI still says that it's advisable to add Tecentriq to chemotherapy in the suitable population. Thank you very much. Thank you, and back to the organizers.
Thank you so much, Dr. Devrat. And I think this has been one of the, early accelerated approval cases, and then having some setback for Tecentriq in triple-negative breast cancer. and also I'd like to discuss this one with panelists in the later half of this presentation today. So with this, I think the chemotherapy arm also forms very important aspect with immunotherapy. So there are settings where we are only giving immunotherapy. There are other settings where we are giving chemotherapy along with immunotherapy, and the chemotherapy arm can actually decide how a person will fare with the combination. So that's kind of one of the learning for Tecentriq in triple negative breast cancer. So thank you, Dr. David, again for your lucid talk. And now we'll move to the next talk by Dr. Kushal Kalra. He is consultant medical oncologist at Sarojini Hospital, and he will speak on new advent for Kadcyla in treatment of HER2 positive residual disease. And this is one area where there's been practice changing things which have happened in HER2 positive arena. Dr. Kushal, Dr. Kaushal, yeah, good to see you back.
Yeah, hi, Dr. Sajjan.
Yeah. So thank you so much for accepting this, and over to you for the talk.
Yeah, thank you, Dr. Sajjan. Nice introduction. So now I will tell about the new adjuvant for the Kadcyla in the treatment of HER2 positive residual disease. So in early, next slide. So Catherine Reschnister, in the early breast cancer, the goal of treatment is cure. Therefore, patients should be given the most efficacious treatment available. Up to 78% of the early breast cancer ultimately relapse. So it significantly impacts the quality of the life of the patient. There is currently no cure for the HER2 positive MBC. So clinical decision point in HER2 positive early breast cancer help to tailor the treatment for the individual's need. Like initial diagnosis for this thing, we have to take into account clinical detail like tumor size, grade, lymph node status, HER2 neo status, hormone receptor status. Then neoadjuvant therapy, goal of the neoadjuvant therapy to reduce the bulk of the disease, to inoperable cancer can be converted into operable, to de-escalate the surgery from the MRM to the breast conservation surgery. And remove this. Third is surgery for the removal of all detectable disease in the breast and the nodes. So pathological assessment of the residual invasive disease to look for the PCR, and ultimately adjuvant therapy, elimination of the residual invasive or micrometastatic disease to prevent the metastasis or recurrence in the curative setting. Yeah, please. Yeah, I think it's happened. Yeah, next slide. Hello, I have briefed about this thing, this slide, initial diagnosis, neoadjuvant therapy need for this. Yeah. So based on the current international guidelines, eligible patients with the HER2 positive early breast cancer should receive the neoadjuvant systemic therapy as per the all authentic guidelines like NCCN, ESMO guideline, AGO guideline, and St. Gallen guidelines. So all are saying same thing for the neoadjuvant systemic therapy in the HER2 positive early breast cancer. So for all, because as per all of these guidelines, Perjeta, Herceptin is recommended by all these guidelines. Dual anti-HER2 therapy in the early breast cancer. Next. So prior to Catherine, 18 cycles of the Perjeta and Herceptin was the standard of care for the patient with the HER2 positive early breast cancer at the high risk of the recurrence or death, irrespective of the neoadjuvant response. So newly diagnosed case, either they will go upfront for the surgery after that 18 cycles of the dual blockage, Perjeta plus Herceptin, or 4 to cycle of the neoadjuvant therapy, followed by surgery, followed by the 12 to 14 cycle of the dual blockage. So patient is the same standard of care, whether in the adjuvant setting, whether patient will go into PET-CR or not, regardless of the response to the neoadjuvant therapy, due to the lack of the evidence to support the changing therapy in the early breast cancer in the cure intent, in curative setting. Next. So the presence of residual disease inform a new clinical decision point to the tailored treatment in the adjuvant setting. If newly diagnosed HER2 positive cancer, early breast cancer with a more than 2 cm in size or node positive, Perjeta Herceptin based neoadjuvant therapy for 4 to 6 cycle, followed by surgery, then look for the assessment. If patient in the PET-CR, then continuation of the neoadjuvant therapy like same Perjeta and Herceptin to complete the 18th cycle. If patient has residual disease, so change treatment to this is the new guideline, new standard of care, to change treatment to the Kadcyla for the 14th cycle in the adjuvant setting. Similarly, we have seen in TNBC for the no PCR, then we used to give this thing capecitabine. Next. So Catherine study design. This is the T1, T4, not 0 to 3 M0 presentation, non-metastatic, HER2 positive early breast cancer, neoadjuvant therapy, minimum 6 weeks, 6 cycle of the chemotherapy, and residual invasive tumor in the breast or axillary node. So patient should not have PET-CR. Then only patient were enrolled in the Catherine study design. Surgery was done and residual invasive tumor, then patient was randomized to either Herceptin arm or Kadcyla arm for the 14 cycles. So stratification factor was like patient at the clinical stage of the presentation, whether they were inoperable or operable, whether hormone positive or negative, whether patient has received Herceptin or dual HER2/neu. Around 15 to 16% patient only received the pertuzumab in the neoadjuvant setting in the Catherine study. Pathological nodal stage were evaluated after the neoadjuvant therapy. Primary endpoint was invasive disease-free survival, and secondary endpoint, the IDFS, second primary non-breast cancer, DFS, OS, DRFI, and safety. Next. So primary endpoint was the same I described, invasive disease-free survival. Secondary endpoint, invasive disease survival as per STEAM definition, including second primary, non-breast cancer, DFS, OS, distance elapsed-free interval, cardiac safety, oral safety, and PR. Next. Next slide, please. Yeah, please change the slide. Hello, am I audible?
Aram, please change the slide.
So inclusion, exclusion criteria and inclusion, HER2/neu positive patients confirmed by the central laboratory, histological confirmed, breast cancer, completion of the more than 6 cycle of chemotherapy. I have this thing described, surgical removal of the all clinical evident disease, pathological evidence of residual invasive carcinoma in the breast or axillary node, known hormone receptor status, and ECOG PS 0 to 1, and ejection fraction must be more than 50%. In exclusion, all metastatic disease and which are not included in inclusion. Next, please. So study populations were well matched, around in randomized IT2 population, 743 in each arm, and around 722 patients treated in Herceptin arm and Kadcyla 40 arms, and follow-up was around 3.5 years. Crossover was from the Kadcyla to the Herceptin was in 71 patients. Next slide. Yeah, please change the slide. So in summary, the early breast cancer treated as a curative intent, patient should receive the recommended duration of the most efficacious available treatment as early as possible to prevent the benefit of the neoadjuvant. Despite the proven benefit of the neoadjuvant HER2 targeted treatment, patient with the HER2 positive breast cancer is still at the risk of recurrence, particularly those who are not attained PET-CR or those with the residual invasive disease. So the aim of the phase 3 Catherine study was to investigate whether the adjuvant Kadcyla improved invasive disease survival compared with the Herceptin arm or not. This was the only aim in the Catherine study. Next. Next. So stratification factors were well balanced between the treatment arm, including inoperable, operable, almost well matched hormone receptor status, neoadjuvant HER2 target directed therapy. As I mentioned, around 19 to 20 patients in Herceptin arm and 19% Kadcyla arm patient received additional HER2 agent along with the Herceptin. And other like pathological nodal status were evaluated after neoadjuvant therapy. These are also almost well matched. Node positive are 46% in both arms and node negative are 53% in both. Next. Baseline demography were also well balanced between the both arm, like age, race, and the region. Next. Similarly, extent of the residual invasive disease, including PATH-CR, pathological node status at the time of surgery was balanced between the both arm. Primary tumor stage at definite surgery and regional lymph node stage at the definite surgery, both are almost well matched in both arms. Next. Similarly, patient who received prior anthracycline and prior neoadjuvant therapy were well matched. Around 75% patient in Herceptin arm and Kadcyla arm, 77% received prior anthracycline. Similarly, around 18% in Herceptin arm and 18% in Kadcyla arm received both pertuzumab and Herceptin both. Around 80% patient had only received Herceptin in the neoadjuvant arm. So the IDFS was the primary endpoint, and Catherine met its primary endpoint, reduced the risk of IDFS event by 50% compared with the Herceptin at a median follow-up around 41 months, 3.5 years. You can see 3-year IDFS was 88.3% in Kadcyla arm, while it is 77% in the Herceptin arm, almost benefit of the more than 11%. So Kadcyla increased the 3-year IDFS rate from 77 to 88.3%, which is statistically significant with hazard ratio of 0.5. Next. The magnitude of IDFS benefit in all subgroup are consistent with the ITT population. In all subgroup, we can see whether patient were inoperable or operable, whether ERPR negative or hormonal positive, whether, but except in this, when this Herceptin and pertuzumab both were given, then it is not significant. Otherwise, in Herceptin alone, it's significant, whether it's not positive, not negative, and in early age, less than 64 years, almost in all subgroup, it's a statistically significant. Next. The majority of recurrence were distance with a reduced incidence in the Kadcyla arm. We can see around it was 22% in the Herceptin arm, but while in the Kadcyla arm, it's around 12% total patient with the IDFS event. In distant recurrence, it's almost benefit of the 5 to 6%, 15.9% in Herceptin arm, 10.5% in Kadcyla arm. So all recurrences, there is reduced incidence in the Kadcyla arm. Next. In secondary endpoint, fewer distance recurrence with the Kadcyla versus Herceptin at the first interim analysis, around 40% reduction in the distance recurrence with the Kadcyla. Next. So OS data are still not mature, but supportive in the of the primary endpoint, and maybe this may separate more when data will be mature. Next. So in efficacy summary, Catherine matched its primary endpoint, significantly reduced the risk of breast cancer recurrence in the patient with the residual invasive disease who have not achieved the PATH-CR after neoadjuvant therapy compared to Herceptin only. Kadcyla reduced the risk of invasive disease survival by 50%, or 3-year IDFS was increased by almost 11.3%. So Kadcyla demonstrated consistent IDFS benefit across all patient subgroup, including hormone positive, node positive, and prior dual HER2 blockage, and was irrespective of the amount of residual invasive disease and concomitant radiotherapy. Kadcyla should not be withheld in patient with the HER2 negative residual disease at surgery. Prior to surgery, it was positive. After surgery, sometime happened, it's negative. So it should not be withheld. Efficacy benefit of Kadcyla were maintained across the key secondary endpoints. OS data are immature at the clinical cutoff with only 98 events only occurred till now. Next. So now come to the safety data in primary analysis. So different adverse events are more in the Kadcyla arm, but only major are only generally low grade, manageable and easily monitored, like fatigue, nausea, thrombocytopenia, transaminitis, headache, radiation and skin injury. Next. But grade 3 adverse event, only significant thrombocytopenia. It was the major concern for the clinician in around 3.6% patient. And transaminitis is also 0.5, but clinically day-to-day practice we have seen. And I have seen in my clinical practice around 5-6 patients had infusion reaction, including one patient had grade 5 reaction, patient expired. But in that case, generic molecule was given, biosimilar, not original Roche molecule, Kadcyla. So I have seen this infusion reaction more in that generic version of biosimilar of that Kadcyla. Next. So overall safety data in Kadcyla are consistent with the known safety profile of Kadcyla. There are high rate of discontinuation rate in Kadcyla arm, around 18%, compared with the Herceptin arm, in which it was only 2%. Most common adverse event leading to Kadcyla discontinuation was laboratory abnormalities, include low-grade asymptomatic, and which are low-grade asymptomatic and reversible. Prior platinum therapy was associated with increased incidence of thrombocytopenia in Kadcyla arm, but did not affect the duration or resolution of the grade 3 to 4 thrombocytopenia. Peripheral neuropathy duration and resolution rates are comparable between treated arms, regardless of baseline peripheral neuropathy. Baseline level of physical and cognitive function and this quality of life were maintained over the course of treatment. There was no clinically meaningful deterioration in the treatment arm. The lack of meaningful difference in average score at each assessment says that Kadcyla tolerated with little impact on function or global quality of life of the patient. Next. So treatment algorithm for the patient with the HER2 new positive early breast cancer, newly diagnosed. If it is T2, the more than 2 centimeter size or node positive, pH-based regime, 4 to 6 cycle, followed by surgery. If patient achieved PAT-CR, then we have to continue pertuzumab with Herceptin for the total of 18 cycle. If patient did not achieve PAT-CR, residual invasive disease there, then we have to give Kadcyla for the 14 cycle. This is the standard of care. If patient has only T1, clinical T1, 0 and 0, then surgery upfront. If node positive, pH-based regime. If node negative, then only TH, Herceptin plus taxane can be given. So prior to Kadcyla, all patients at a higher risk of recurrence received 18 cycle of pertuzumab and Herceptin, regardless of the timing of the surgery. Kadcyla now offer a tailored approach based on the neoadjuvant treatment outcome. So it's the standard guideline for the all, it has been adopted by the all standard guidelines, NCCN, ESMO, EGO, St. Gallen guidelines. Next. 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 Come to next slide. Yeah, it's the same. The use of neoadjuvant therapy enable response directed therapy in the adjuvant setting. Same I told. So patient who have a PAT-CR after pH-based neoadjuvant therapy still at a risk of recurrence for death or should receive pH in the adjuvant setting to complete 18 cycle till now. Now it has been changed. Next. Come to the summary. Next slide. Next, come to the summary. Yeah. So Kadcyla has introduced a new decision point in HER2 positive early breast cancer. Adjuvant treatment should be optimized based on the response to neoadjuvant therapy. Patient with any amount of the residual invasive disease after HER2 directed neoadjuvant therapy should receive 14 cycle of Kadcyla in the adjuvant setting as recommended by the international treatment guidelines. Those who achieve a PCR after HER2-directed therapy still have a risk of relapse should continue with the pertuzumab Herceptin to complete the 18th cycle in adjuvant setting. So the key message is, next slide, Catherine marks a new standard of care in the patient with the HER2 positive early breast cancer. Early breast cancer treatment is the same I have already explained. So key point, Catherine marks a new standard of care for patient with HER2 positive early breast cancer. So that's all. Thank you.
Thank you, sir. Thank you, doctor, for your nice presentation. So Dr. Sajjan sir is there?
Yeah, I'm here, Ekaji.
Yeah.
So,
Yes.
okay. So after these wonderful presentations from my esteemed speakers, we like to move to the next part, which is the panel discussion. And I'd like to invite the panelists for today evening. Do we have Dr. Chaturbuj Agarwal here? Dr. Chaturbuj, have you joined, sir? Dr. Chaturbuj, Dr. Sameer Khatri. Dr. Chaturbuj is consultant medical oncologist at RGCI New Delhi. Dr. Sameer Khatri is my senior and director and HOD at Department of Medical Oncology, Shanti Mukund Hospital, New Delhi. Dr. Tarachand Gupta, if we could have, yeah, I'll request that panelists to put their mic on and also, if possible, camera. Dr. Tarachand Gupta is consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. And Dr. Kishore Kumar Kota, he is assistant professor medical oncology at TMC Muzaffarpur. So, do we have all the panelists before we start? And can we also put the presentation from your side, the organizers?
Good evening, sir. Sir, Dr. Sameer sir and Dr. Tarachand sir is joining in few minutes.
Okay. So we'll start the presentation because I think we're slightly ahead of the time. So like 5 to 10 minutes. So should we just request them, they will start joining in. So before that, I'll start having some conversation with my panelists here. So can we start the case? Once the other panelists join, then we could involve them in the case. Okay. So this case is 55-year-old lady. She's T4N2M0 clinically. ER negative, PR negative, HER2 3+ by immunohistochemistry. Next slide. Okay. I'll start with Dr. Chaturbuj. Dr. Chaturbuj, with such a clinically evident patient, first is that what do you do to stage, and how do you decide when you will start neoadjuvant chemotherapy in your patients who are ER/PR negative, HER2 3+? Dr. Chaturbuj. Dr. Chaturbuj, I guess you are on mute. You have two ways by which you are joined. Could you log in from one? I can see you in one of the channel, and another one I can only see your name. I can't hear you.
Sir, Sameer sir has joined.
Okay. Welcome, Sameer sir, and we just begin with the panel discussion. So,
Sajjan, hi.
Hello, sir. So, can we just go back to the last slide? I was not able to hear Dr. Chaturbuj very clearly because he was trying to say something, but I couldn't hear him. So, we're discussing HER2 positive breast cancer and the different scenarios. We start with the first case, which is 55-year-old lady, clinically T4N2M0, ER negative, PR negative, HER2 3+ by ISC. So I started with Dr. Chaturbuj. Dr. Chaturbuj, could you answer the first question? Like I said, when do you decide you will take such patients for neoadjuvant chemotherapy? How do you take treatment decisions in HER2 positive breast cancers in 2021? Okay, so Dr. Chaturbuj will join from other device. Dr. Kishore, till the time I like you to answer this question.
Yeah, sure. In this case, first we have to stage the patient. I have two options to stage the patient. One, we can do, one is ultrasound abdomen, the most common sites to exclude the metastasis. One ultrasound abdomen, I want to exclude the liver metastasis. And I will prefer bone scan to exclude the bone metastasis and chest X-ray to exclude the lung metastasis. And there is another option for me also, which I can prefer is PET scan. I can exclude at a time all sites of disease. I can exclude bone, liver, lung, all at a point of time. If patient is affordable, I will go ahead with PET scan. If patient is not affordable, then I will go ahead with ultrasound abdomen and bone scan and chest X-ray. First, in this case, I want to exclude the metastatic disease. And then if there are no mets, now coming to the therapy-wise T4 and 2. In this case, I want to give initially neoadjuvant chemotherapy.
Okay. Dr. Sameer, sir, which are the patients, because nowadays there is a lot of buzz with the neoadjuvant chemotherapy or chemoimmunotherapy, HER2 positive breast cancer. So which are the patients which you actually discuss with your surgeons and decide that even if they are operable, you're more happy to give them neoadjuvant chemotherapy? So where is that you draw a line that this is the patient you should take for upfront surgery, and this is the patient you should send to me, or we should start with the neoadjuvant chemoimmunotherapy?
So what has been our practice now with new data and all and dual blockage, and we are doing a neoadjuvant for everyone above T2, T2 and above. We are doing a neoadjuvant for all, as you might be discussing also the importance of pathological CR. So, and how pathological CR is important for disease-free survival and overall survival maybe. So what we are doing at our institute now is T2 and above. We are giving to all the patients the neoadjuvant, and if patient can afford, then dual blockage.
So I agree with you, sir. In fact, there's a new data which shows even tumors which are centimeter, more than 3 centimeters of tumor, which are even still T2. Even such patients, if they are not positive at T2 and 1, we're still going at, especially the size of the tumor is more than 3 centimeters. There's a lot of emerging data which shows that such patients can also benefit with
even T1C. Yeah, definitely.
Okay, sir. Next slide, please. So with the various guidelines are there, like sir said, the initial guidelines have been like, if you just see the NCCN guidelines have said inoperable breast cancer is it's a N2 disease or N3 or T4. So these are the inoperable breast cancers. Operable breast cancers are which HER2 positive with triple negative, T2 or higher, or N1 or higher. These are the patients which where you might use neoadjuvant chemotherapy. So St. Gallen's also has said that it should be preferred approach in the stage 2 or stage 3 HER2 expressing or triple negative breast cancer. So in both these settings, most of the guidelines are suggesting that neoadjuvant approach might be better, even if the patient is T2 or N1. So these patients might be taken up, especially even T2, they are more than 3 centimeters. There's data which shows that they might benefit from neoadjuvant chemotherapy. Next slide.
Sir, good evening. So I am back and that device was not working. Sorry for the inconvenience.
Fine.
Sir, can I ask one question in the other way around? So we all say that now HER2 positive, we should use neoadjuvant therapy. So if we ask the other way around, maybe you or Sameer San can answer. Is there any subset of patient HER2 positive where we can directly go for surgery? Means which subset of patient you will prefer upfront surgery?
So I think Dr. Sameer is the most senior one amongst us, and
maybe less than T1A and B, we can go in for surgery. And 1 or 2 patients are like this only, though they land up with surgeon and they operate also. And at times, though it's not there always, but at times they don't wait for ERP or HER2 report also, and they do the surgery also. So these are the type of patients who undergo upfront surgery in HER2. We always say to our surgeons, go in for neoadjuvant. There is ample data now for neoadjuvant that favors neoadjuvant therapy. But few patients do land up with surgeons and they do surgery. And at times they land up in non-onco centers also. And especially these type of patients, I am catering to many of these patients, and we give them adjuvant only then. So apart from that, T1C, as Sajjan said rightly, more than 3 centimeters, all patients should receive neoadjuvant. So, Chaturbuj.
So you have a very strong breast cancer tumor board. So do you see this practice evolving in Rajiv Gandhi, like with the more data emerging, especially in HER2 positive or TNBC towards neoadjuvant? So are the surgeons really willing to give these patients to you before they put a knife on them? So what is your take on the patients you're seeing over the last 2-3 years? Because such meetings, they're also involving many of the surgeons. Unfortunately, we don't have any surgeon into a meeting, but then the data shows that like many other malignancies, like we moved in esophagus, in sarcomas, in rectum, we moved towards neoadjuvant and then going for definitive surgery. So you see a change in your surgical colleagues at Rajiv Gandhi over the last 2 years?
Yes, sir. So, sir, one submission actually, since last 1 week, I have left Rajiv Gandhi. Now I am not in Delhi.
So where are you now?
Sir, I have moved to Middle East. I am in Bahrain.
Arre Good.
Dr. Sameer will plan his next meeting in Bahrain.
Yeah.
We now have a sponsor in
वहीं चलते हैं हम Bahrain में. हाँ.
So we are looking forward to see you in Bahrain.
Yes, sir.
Okay, before I left.
But before I left, sir, there was definitely a change in practice. Means now at least all node positive patients, they are coming for upfront neoadjuvant chemotherapy. But as Sameer so rightly told, what practically is happening is if the patient goes to surgeon first, then there is no chance. Means node negative tumor, definitely nobody will send for neoadjuvant therapy. But yes, more than 3 centimeter tumor should receive neoadjuvant therapy. But you asked me, so things are definitely changing.
Yeah.
Now we have a competition also between surgeons. There are 2 surgeons, so they have to.
Okay, now things have become more competitive. And just to ask out of curiosity, is Dr. Akhil Jain also there in Bahrain or he's not there?
No, he's in US.
Dr. Akhil Jain is in US. Okay.
But Bahrain में भी तो है ना एक medical oncologist from India.
हाँ है एक है डॉक्टर चतुर्भुज अग्रवाल है सर वहाँ पे.
अरे वो तो अभी आए हैं, अब तो छा जाएंगे बिल्कुल. Very good. Good.
So today we are lucky to have international faculty in our.
Yes, now we have international faculty. Good.
Thank you. Acha, okay. So we move ahead. I can see some of my other panelists. Dr. Tarachand, I'm able to see him over the bridge, but only bridge is visible. Dr. Tarachand, yeah, can you? Dr. Tarachand?
Yes, yes, I am there. Yeah, Dr. Tarachand.
Okay, welcome, yeah. Okay, can we move the next slide? Next slide, then I'll ask a question, Dr. Tarachand. Yeah. Okay. So I think this is we've been already discussing. Can we go to the next slide? So I think we all know that now the gambit of neoadjuvant is actually evolving, and we are having more and more patients in breast cancer for neoadjuvant chemotherapy. So given a choice, HER2 positive patient, what would be your preferred choice? Dr. Tarachand, what would be your preferred choice?
Yeah, I will go with the TCHP.
Okay.
As per the Neosphere, I will prefer the TCHP as a neoadjuvant chemotherapy.
TCHP is your choice. Dr. Kishore, TCHP or any other regimen, and why?
We are preferring here, most of the patients are not affordable, but most commonly we are using weekly Paclitaxel plus trastuzumab and for them followed by AC.
Okay. So I assume that you're working in a sector where probably pertuzumab is not easily available. So if pertuzumab is not available, so yes, I agree with you. You could have a combination of trastuzumab with taxanes or add carboplatin, or you could also have a combination like AC followed by AC followed by taxane plus trastuzumab. So which could have a fair, I would say, pathological complete response. So coming to Dr. Chaturbuj, I know Bahrain, everybody can afford everything, but yes, if finances are an issue, would you prefer anthracyclines to be a part of the regimen, or you still not like anthracycline and you only go for anthracycline-free trastuzumab based combination?
No, sir. So I think TCHP would be the preferable choice. If patient cannot afford pertuzumab and if it is node positive, then I would like to go with AC followed by TH, which will be more preferable than TCH.
So yes, in case because there was some data where probably some of these patients had topoisomerase 2 overexpression also, which had benefit of adding anthracycline. But yes, with the evolution of TCHP, many of us have now moved away from anthracycline containing regimens in our patients. So affordability is not an issue. TCHP has become another favored regimen for most of the oncologists. Dr. Sameer, sir, any thought or any difference of opinion?
Again, no, I am using TCHP, but there is some thought when node positive is there and maybe role of anthracycline is there. There was some trial was there which was showing, but we are now very comfortable with TCHP. And if patient cannot afford, then 4AC followed by Taxol and trastuzumab.
So I think all the panelists agree with what
there's
a consensus among the panelists. Next slide, please. Next slide. So I think we already discussed this. Will skip. Next slide, please. Next slide. Next slide. We already shared these files with our So this patient underwent AC4 followed by TH12, underwent MRM, was found to have YP-T2-N1. There were 3 lymph nodes which were positive. Now coming to adjuvant setting. So Dr. Tarachan, in your settings with residual disease, what is your current practice?
Yeah, if I have given a TCHP or any other anti-HER2 therapy in neoadjuvant setting, and there is a residual disease after the neoadjuvant setting chemotherapy, then I will go with the Catherine trial and give the TDM1 for the 14 cycles remaining.
So here the P was not given. So does it make any difference, or you still go with the Catherine data, which P not being given the neoadjuvant setting? Because now we have some generic.
No, there is no. Any anti-HER2 therapy, if it has been given, and there is no PATH CR after the neoadjuvant, then TDM1 is the right choice.
Okay. Dr. Chaturvedi, your take on such patients?
Only 20% of patients in Catherine, they received pertuzumab. Rest all the patients, they have received only trastuzumab. So definitely, if patient can afford, TDM1 is the right choice.
Okay. Okay. Dr. Sameer, sir?
Yeah, I agree. So in fact, both if dual or single trastuzumab or dual blockage was there, so numerically dual blockage, they did better with TDM1 in fact. So, but even if trastuzumab is given, then also TDM1. So as Chaturvedi rightly said, 80% only received trastuzumab. So, okay. Patient should receive TDM1.
I have a question. Can I ask?
Yeah. Go ahead. Yeah,
sir, if patients received paclitaxel plus trastuzumab weekly, 12 weeks, and then he underwent surgery, then residual disease is there, then what about the role of TDM1?
The role of TDM1? Okay.
Yes, 12 cycles of PPLHS she received, and then she underwent surgery, and then residual disease came positive.
Yeah, it was a weekly regimen.
Then AC was given. Then what about TDM1?
Yeah, it was a weekly regimen. So actually, effectively, there were only 4 cycles of this was given. It was a weekly schedule.
Patient should receive 14 cycles of 14 cycles of TDM1 as per the Catherine trial, plus radiation, of course. Radiation should be
with AC, with first surgery, and then followed by AC, and then followed by TDM.
He wanted to ask that patient has not received any anthracycline. Patient has received only Taxane and trastuzumab,
yes.
And then surgery, and then there is residual disease. So will it?
And then residual disease. Yes.
This is what he wanted to ask.
Okay.
Yes.
So if the patient has not been exposed
yes.
For example, the patient was exposed to TCH. For example, we have patients who have been exposed to TCH only. So no anthracycline exposure. So Dr. Chaturvedi, what is your take in such patients?
So again, I think, sir, we have sufficient data. Anthracycline, if patient has not received, then also we can offer TDM1 because patient has already received Taxane. As you only told that there are anthracycline-free regimen also in Catherine.
Yeah. So I think the evolution of these the Catherine, actually the principle behind Catherine was whether a residual disease could have a more impact by using a TDM1 instead of having dual blockage or only a blockage which will only have immunotherapy there, because most of such patients would have received chemotherapy and they would have ended with their chemotherapy. And so the TDM1 brings in chemoimmunotherapy for 14 cycles, and that probably adds to more of this distant metastasis-free survival in such patients. So that yes, the regimens, if they were used TCHP, probably the initial pathological response was very high compared to using a dual blockage in the first line setting, where the pathological response rates are less than 40 or 45%. Next slide, please. Next slide. Next slide. So with this, we already discussed. Next slide, please. So we've already discussed alone versus TDM1. I think the other option is now the patient is able to afford pertuzumab. For example, the patient gets funding from the government. So would you still consider, instead of TDM1, would you consider trastuzumab plus pertuzumab as 14 cycles? Is there a patient, or you will still prefer TDM1? Dr. Chaturbuj, any thought on this?
No, sir. I think we will prefer TDM1 only. Patient can afford, so TDM1 is the standard of care as of now, whatever data we have. So we have affinity data, but it has shown only 1.2% benefit with addition of pertuzumab, even in ERPR negative subset also. So I don't find any place of pertuzumab in adjoint setting.
Dr.
As far as TDM,
Dr. Tarachan, the other option, trastuzumab plus niratinib, if that was available to us.
I will agree with Dr. Chaturbuj. Then as of now, the TDM1 is the standard of care as an adjuvant setting if the finances are not a constraint.
So all the panelists, I'd say they agree. If their finances are not an issue, they would like to use TDM1 as their adjuvant, especially in patients who have residual disease, based upon the CAPTAIN data, which shows there's a significant difference in the distant failure-free survival and also trends towards improvement. Though the data is not mature, but then probably there might be some benefit in the OS also in the later when we have more 10 years data. Right now we don't have any OS difference, but yes, distant metastasis-free survival is a huge difference. Next slide. So we just saw this. So invasive disease-free survival 88.3% versus 77% at 3 years. That was really remarkable. The number of events were almost double in the only trastuzumab arm compared to Kadcyla, which was 91, whereas 165. The hazard ratio was 0.50, and this is something really, I would say, practice changing. And this is what has actually led us to believe and use more of TDM1 in the adjuvant setting. Next slide. So I think similar question with the patient used. We had a lot of chemotherapy. We had FEC3, THP, and what then? Even after that, what would be your preferred post-op regimen? So in one word, you could just answer, Dr. Chaturbuj. HPH, TDM1.
So, but patient has same post-op findings. So I think TDM1 again.
TDM1.
Okay.
Yeah.
Dr. Tarachan, any difference in such patients?
Yeah, TDM1 is the right choice if the there is residual disease.
Okay. Sameer sir, any difference?
No, TDM1. Yeah.
Okay. And Dr. Kishore, any thoughts? Any difference?
Yes, no, TDM1, sir, TDM1.
So all the panelists agree that even whatever the pre-op regimen was there, if there's a residual disease, then people have now developed trust over TDM1 for their patients in the adjuvant setting with the residual disease there. Next slide. So I'm just skipping this because repetition of these things. Next slide, please. Next slide. I'll just skip this because none of us, I think, are considering niratinib. Any of you would like to comment, yeah. Any of you would like to comment niratinib?
International faculty शायद कुछ comment कर ले.
No, sir. Even if you consider niratinib, it is not available. It is not available here also.
अच्छा, वो डायरिया में ही बैठा रहेगा बेचारा.
80% diarrhea rates.
95%. 90% diarrhea.
90% diarrhea, yeah. Okay.
Yeah, and there is now talk of giving prophylactic loperamide for that.
I think this drug did not really pick up well in being there in the market for more than I think a decade, but has not been able to have any mark. Yeah, next slide, please. Next slide. So this patient received TDM1 for 14 cycles. Patient at 8 months had headache. MRI brain showed single cerebellar metastasis. SBRT versus whole brain versus surgery. Just a quick take by my panelist, Dr. Chaturbuj. Single solitary metastasis in cerebellum, SBRT and whole brain RT versus surgery.
So, sir, I think I would prefer surgery because it's a single lesion. The benefit of surgery over SBRT is simple, that we can again get a IHC and again know the nature of the disease.
Okay. So, the Dr. Sameer, your preference for single solitary metastasis, especially resectable in the brain, you go for surgery or you go for SBRT?
So if it's really operable, then surgery. But I hardly see any surgery done for that. So SBRT.
Because we don't get
only
it.
If it is a solitary site. So maybe.
Because
I have one patient.
Yeah. Many times, sir, as medical officers, we are also not sending references to a neurosurgeon. I know there's some age. We are more happier.
At times they land up with neurosurgeon only.
So, Dr. Tarachand, at your center, your surgeons are happier or you are happier?
Yeah, usually patient after the completion of treatment, whenever has a headache, they usually visit the neurologist and then the neurosurgeon, and then patient comes after the getting surgery done. So
exactly.
I think this is the right choice, and patient already has decided the best treatment.
Okay. So yes, I think the data shows.
Once the patient visits the neurosurgeon, then our headache starts.
Are you able to dodge the neurosurgeon or you give it to the neurosurgeon?
हमें टिश्यू मिल जाता है, टिश्यू के साथ में कुछ और आ जाएगा.
Okay. So next slide, please. Next slide. So, like, they're not my slides, but yes, the patient underwent SBRT, and post SBRT, the patient had leptomeningeal enhancement, CSF cytology was positive. Really bad things happening for this patient quite soon, early on. This is not a typical case. I would not say that these are typical cases because yes, most of the patients do well when we are giving them HER2 blockage, and they don't end up failing so soon. But yes, this patient did really bad. Next slide. Now coming to the next question. Such patients landing up with early failure in the brain, despite your local control in the brain. So among these choices, Dr. Chaturbuj.
Tucatinib, capecitabine, trastuzumab, based upon HER2 claim, 66% CNS response rate. I think that should be the first choice.
Okay. Dr. Tarachand?
I think I will differ from Chaturbuj sir here, that I think tucatinib is in third line or beyond. At present, it has not come in the first line, and patient has already the more than 6 months of the progression-free survival. So theoretically, we can re-challenge with the trust that the Cleopatra regimen, but still I would go with the different drugs which have not been used. That is the lapatinib plus capecitabine with the intrathecal trastuzumab can be given in the positive CSF cytology.
So your choice is intrathecal trastuzumab and lap and cape. So Dr. Sameer, your take.
Yeah, again, this patient is not doing well. So survival is not very good. I will go in for tucatinib, capecitabine, and trastuzumab. And I have no experience of intrathecal trastuzumab.
Okay.
Heard a lot about that. So maybe I will like to try it.
What about tucatinib? Because I don't have any experience. You have any experience with tucatinib? We didn't have any experience with tucatinib.
No, sir. We have not given to any patients tucatinib, but intrathecal trastuzumab we have given to 2 patients.
Okay.
So one patient did good.
So was it the normal trastuzumab which we use in our practice, or it was something different?
No. It actually, ideally, it is supposed to be different trastuzumab. But since we don't have the trastuzumab, so we were giving normal trastuzumab because we actually consulted Dr. Jyoti Wadhwa ma'am. Dr. Jyoti Bajpayee ma'am. She has actually given to 3 patients. So it was already published from TMH.
Okay.
So there was one patient. I am sure, sir, you must have seen that patient. She's an old patient. She was professor. She was an old patient. You must have seen her.
Yeah, Dr. Kishore, any difference?
No, I will prefer capecitabine, lapatinib, and tucatinib. We never. I have no experience with tucatinib, and I not have experience with intrathecal trastuzumab also.
I think intrathecal will be really good because nowadays they're coming up with. You're very surprised they're coming with a combination of Trastu plus pertuzumab subcutaneous also. So. So I think things will become better with these small depot preparations coming up for especially these monoclonal antibodies. Things might be definitely better. I don't know if they are able to give them intrathecally, how would they respond? But short of that, yes, if tucatinib is available anywhere, this could be tried. But yeah, Dr. Achan, you want to say something?
Yeah, just I think I am firm with the decision. Hello?
Dr. Achan, there's a lot of movement on your, you're all over the bridge.
Yeah. This is the benefit of the webinar. No? Yeah. You can do this from anywhere.
Yeah. Okay.
So you can see that the earth is moving. No? I am proving that the earth is still moving.
Yeah. A lot of movement. It appears like you are just going to read this. Okay. So I think all the panelists agree that yes, we have certain combinations which we can use based upon our own clinical judgment as well as our practical experience with these drugs. But most of the patients end up having lapatinib plus capecitabine in our clinical practice, especially if they are not benefiting with PD-1 or trastuzumab or pertuzumab. But yes, we could have these drugs. Next slide, please. Next slide. I don't know. This is just this was a similar patient who would have developed pain. I would just yeah. Next slide. So this has already been discussed. So if the patient has got a candidate who is a CT2 or clinically node 1, we could go for TCHP or AC followed by THP, and as the disease is there, TDM for 14 cycles. Neuratinib is still a question mark. If there's the disease is pathologically complete response, we could go for H plus minus P in most of our patients, or H plus P. Next slide. So now this is another case. 40-year-old lady presented with severe backache. She was found to have locally advanced breast cancer with extensive bone mets and lung metastasis. So clinically it was T4D and CM1. And it was ER positive, PR positive, HER2/3+. Next slide. So the first question, Dr. Chaturvedi, do you have a baseline imaging for brain for all your HER2 positive NBC patients?
No, sir. So we do brain imaging for breast only if the patient is symptomatic, for if there are some symptoms and we are suspecting.
Okay. Dr. Sameer, brain imaging is a part of your staging workup?
Yeah, we are getting it done now. We are getting it done. For past 1 or 2 years, I have burned my fingers in a wrong way. So we are doing it regularly now.
Okay. Dr.
Just 2,500 rupees. Why to unnecessary?
No, sir. We are not doing. If patient is symptomatic, then only I am doing. Or else we are not doing.
Okay. Dr. Gupta?
20-30% will be asymptomatic.
Yes, if the patients are symptomatic, then we are doing MRI brain, otherwise not.
So the panelists have a disagreement here, and I think some of the panelists say I'll get it done, others are saying okay. And what do we do for asymptomatic brain mets? Do we start, like we observe them more closely? Dr. Sameer, but if the patient is found to have some
prognostic wise, so the thing.
Okay. Next slide. I think we just skip it here. Next slide. So for metastatic patients, how do you what is your combination? What is the preferred combination, Dr. Chaturvedi? And how does it depend upon the patient's performance status or some other parameters? In metastatic setting, triple positive breast cancer, what is your choice? Triple positive.
So, sir, one thing, just last, you asked Sameer, sir, that if the patient has asymptomatic brain mets, then what will you do, radiation or chemotherapy? So we have to look at the systemic bulk of the disease. If the patient has a lot of systemic bulk and the brain metastasis is single and asymptomatic, we can avoid addressing it. We can start with systemic therapy. So now coming to systemic therapy, obviously taxane plus trastuzumab is the treatment of choice in all patients, with addition of pertuzumab if the patient can afford. But sometimes if the patient is frail, the disease bulk is very much high, then I would sort of avoid pertuzumab in the first cycle. We would just give trastuzumab and taxane, and we will add pertuzumab from the next cycle if the systemic bulk is very high. But this, as in this patient, I would definitely prefer THP for 6 cycles.
Dr. Sameer, for triple positive breast cancer, always chemotherapy as an addition, or you use AI, or for example, this is a premenopausal lady, so ovarian ablation along with your hormonal treatment along with the HER2 blockage, or chemotherapy?
But we are doing always HER2 blockage first.
No, HER2 blockage is fine. We are doing, but chemo or hormone?
Along with chemo. Sorry. Along with chemo.
Okay. So, Dr. Tarachan, if the patient is supposedly, for example, 70, triple positive, what would be your choice? Do you always?
So you, you want to avoid trickily chemotherapy. So we will avoid also in the elderly people. If the patient is not fit for the chemotherapy, then we can give a trastuzumab plus the AI alone. If the patient is fit for the chemotherapy, then we can go with the THP of the 6 cycles followed by TH plus AI.
So what about GnRH analogs are upfront along with THP? Your opinion? If hormone positive in premenopausal.
Yeah, so I think Chaturbuj can answer. Chaturbuj was the leader of the breast clinic at Rajiv Gandhi. He has a lot of experience. He has more experience than many of us here.
So my apologies, sir. You are left with just 5 minutes to conclude the panel discussion. Thank you.
Don't be apologetic. We are very happy.
Okay.
Okay.
So he was asking, sir.
Yeah.
So he was asking only trastuzumab, pertuzumab, and hormone.
Yeah. So
premenopausal, hormone positive, HER2 positive, metastatic, and I am giving THP. Now my question is whether what about your opinion on GnRH analog along with that first cycle of chemotherapy? We will give hormonal therapy after completion of chemotherapy with trastuzumab. My question is, what about adding GnRH analog with THP?
I think there is no role of adding GnRH analog with chemotherapy, because anyway, when we are giving chemotherapy, the ovarian functions are going to suppress automatically. GnRH with chemotherapy is given only in triple negative breast cancer when we want to give a chance of fertility preservation. Otherwise, I don't think there is any point in giving GnRH analog.
Okay. So, yes. Any difference of thought? Any different? Dr. Sameer, would you like to comment something or add something here?
No. It's absolutely fine. Okay. While giving chemotherapy, why to give GnRH analogs?
Okay.
So only after finishing the thing, and
so actually, unfortunately, I'm having a very bad day with the patients here today, because this lady also after 7 cycles has started having blurring of vision. I know which case are they giving me today from the sponsors.
You start.
So again having extensive leptomeningeal and brain metastasis. No, Chaturbuj, I will refer such patients to you, even if you are in Bahrain. I'll not be happy. I'll not be happy.
Tocatinib dega wo. We'll start giving tocatinib to that.
Okay.
Ideal patient for tocatinib now.
So next slide. So I think in the short, we are right bang on time. So I like to really stop it here, and we've been actually having this panel discussion for more than 40 minutes, and it didn't, because our lecture started fast, and then we are about to finish at 8:30 was our time. So with this, I like to thank all my panelists for such lovely interaction, and Chaturbuj, really happy to see you representing Rajiv Gandhi as well as making us proud in the foreign land, and we hope that you have a great career there. And Dr. Sameer is always smiling because he like to visit the country Bahrain, and we request you that very soon you have a international meeting there, sir.
अब सज्जन के साथ ही चलेंगे भैया. हाँ, जैसे सिंगापुर गए थे, याद है? अब यहाँ चलेंगे. Definitely.
को भी लेके चलना आपने.
बुलाएगा तो.
पुल पे तैयार है हम.
Definitely, sir.
Chalo, good, yaar. Good.
Dr. Kishore and Dr. Tarajan, thank you again, and thank you all of you for joining us for this lovely meeting here. And I'm sending this back to the organizers, and over to Ekta ji.
Thank you for the lovely discussions, and good night, everyone.
Okay,
So
bye-bye.
close our
Thank you.
meeting. Bye-bye, everyone. Bye-bye.
Before you say
Bye.
good night, I'd like to thank you.
Can we go offline?
Ma'am.
नहीं हो गया. Thank you हो गया भैया.
Thank you हो गया. Okay जी, thank you, thank you. So are we offline?
Yes, yes.
Thank you, ma'am. Thank you so much.
Thank you. Welcome, sir. Welcome, everyone. Happy to help you.
Alright, thank you so much, ma'am. And thank you all the team members for this meeting.
Thank you, Aram. Thank